All right, everyone, we'll make a start now, I think. We've just gone past 3:30. It's wonderful to have you here, so welcome. Thank you very much for coming. Before we begin, I'd like to acknowledge and pay respects to the traditional owners of the land on which we meet, the Gadigal people of the Eora Nation. It's on their ancestral lands that the University of Sydney is built. As we share our knowledge, teaching, learning, and research practices within this university, we also pay respects to the knowledge embedded forever within the Aboriginal custodian of country. So I'll just introduce myself first. My name's Bryony Winters. I am an academic at the University of Sydney. I've just started up my research lab and I'm really interested in sort of pain mechanisms. So I'm very much a basic researcher and it's wonderful to be here with you. I will also introduce my co-chair.
Hi, my name is Farishta Purkazami and I am a senior lecturer at the University of Sydney, Discipline of Physiotherapy, and I'm also a program director for the new Doctor of Physiotherapy program. My research is also focused on pain, especially with interest in social interventions for pain, in particular arts for health. So thank you. I'll hand over to you. I'll be chairing this section.
So just a little bit of housekeeping. So the organisers have asked us, can you please take your bags and everything with you when you leave? It's a fairly obvious one. And we're going to have networking drinks, and that's going to be starting at 5, and it's going to be for about an hour. So please do stay behind if you'd like to say hello to everyone. Okay, so and he's fascinated by how reconceptualizing pain may change pain treatments. As a part of his PhD, he developed the concept of pain inventory, or copy. He is now working on developing testing educational resources, particularly in schools. Josh worked with the TED to make 2 online animations with millions of views. I've actually seen one of those, they're really cool. And he co-founded a pain science interview platform, One Thing. And he's now a children's book author of 5 books about pain, Zoe and Zach's Pain Hacks. Josh dreams of a generational, conceptual and behavioral change regarding the complexity of pain. Okay, thank you very much, Josh.
Cool. Thank you. Hi, everyone. Thanks for having me. I'm excited. I'm sure if I say slip, slop, slap, we're in Australia. Most people are aware of this. If you have young kids now, they probably wear a hat and sunscreen. They probably do that, right? There was behavior change. But that started in the 80s, the conceptual change. Like recycling is normal. Like we've done this as a society. We're able to change the way we think and the way we behave. And so I guess the challenge for me, the big idea to intentionally use the pun, the big idea I want you to think about and help us with in the Q&A is, could we do this with pain? Could we, what part of Lippenstorf could we bring to primary schools, for instance? Like, do they need to know about descending inhibition or not? And what are those critical bits that actually help people's quality of life, or whatever that perfect outcome would be? Anyway, let's dive in. So the title was on the previous slide. So as it was mentioned, I'm a children's book author now. I need to mention that. It's very, very exciting. A few thousand people read most of the papers I write. But when you do like a TED video or something big, it's amazing how much engagement you get. And that's really exciting to me. I think I'm fascinated, if we go from basic research right to the other end of implementation and what does it look like in society. I'm interested in that. Is what's those ideas that are the minimal amount of education necessary that is beneficial? And that's hard, and we don't know all the answers, basically. That's the summary of my talk. But let's see where we go. So I'll give you a few facts. We're neuropathic pain experts. Let's become pediatric experts. Kids challenged by chronic pain miss 22% of school. That's the most recent systematic review. I thought people would go, oh, when they heard that. That's great. That's a day a week. That's 1 year of primary school or high school. That is a lot of missed participation in their life. Fact number 2, 1 or 2 kids per class are challenged by chronic pain. I still struggle with this data. I didn't grow up with chronic pain. And until I reflected, I didn't really think about this as being a true case. So for you, there were people in your class, they probably were the ones not doing sport or missing lots of class. But there are so many people with chronic pain and challenged by chronic pain, even from childhood. We heard this before, pain sucks, it costs heaps. I think we don't need to dwell on that too much. But what's interesting from a pediatric perspective is it's not just terrible now for the child or teenager, it's also horrible down the track. Like it predicts long-term disability, academic outcomes, work absence, opioid use, mental health outcomes. Like there's so much data now. All the longitudinal studies are painting a very sad picture in a lot of ways. So I've shared 4 facts so far. They're not, do you know some people go, oh, fun facts? These are not fun, are they? I've tried to make them look a bit fun. This one's a bit nicer. There's preliminary data, a lot of the evidence from like CBT land and some of the pain education space is showing that learning something is probably helpful, but it's working out what that is that I'm really fascinated in. So we're going to cover some research, some resources, initiatives, different stuff, and then some more research. And I can't wait to hear what the questions are. So let's get a definition on the table. So I mentioned conceptual change, and I think that hopefully that's the theory. So the obvious thing would be, what are we changing? What's the concept? So we'll call it this. So someone's beliefs and knowledge of what pain is, why pain exists, how pain is experienced. If you put that text into Bing AI, that's what it looks like. It's interesting and topical. But yeah, it looks horrible and you have weird eyes. No. So yeah, what, why, and how of pain. I'd love to hear what your concept of pain is. And to do this in one of my PhD studies, we got kids to draw whatever the word pain makes you think of. It was like it started as an icebreaker activity, but it turned into a really interesting conversation starter. So for the quieter kids, they kept coming back to their drawings. I've given you enough time. Love to think, what would you draw? This is a qualitative study, so we can't draw huge conclusions or anything. But all the kids who didn't have chronic pain in this study, small sample, but they all just drew injuries exclusively. So bleeding knees, bloody stuff, broken bones and things. Kids with chronic pain, that was kind of the other group. They also drew some of this stuff, but they drew sad faces, tears, broken hearts. And your heart, like I was the interviewer, it just sinks as you're hearing this. The parents weren't allowed to speak. They're sitting there and everyone's just like, oh, like this is affecting their beliefs and their understanding of pain. But all the other kids in the class aren't thinking that way when they hear the word pain. So there's kind of all this stuff happening underneath, all this biology happening under our skin in terms of the way we think. So this is back 2019. We came up with this framework to just get us started because we're like, this is a mess. It's kind of like a puddle. You don't know what's in a puddle. If you stamp in it, it's like communicating it. But like, what are the raindrops that are contributing? There's personal experience seemed to be a big deal. Some level of knowledge, like if they've watched Operation Ouch or not, or they've seen the Discovery Channel or something. And then pain in the world around me was really fascinating. A girl, she's like, oh, my mum had a knee replacement. My neighbor had a knee replacement. So if you have pain, just got to have a knee replacement. And like internally, I did that, what you just did, but I didn't laugh out loud. And I said, what about like headaches? And she just looks like deadpan, you need a knee replacement if you have pain. And that's because before the age of 12, humans aren't thinking abstractly. And so things are very concrete. If something happens to someone around them, it's kind of like they don't have that sense of self-identity so much yet. There's also other raindrops we've started filling them out a little bit, but there are probably heaps of other raindrops in this puddle. And we don't know what the percentage composition is. It's just like, it's so hard not knowing so many things. And the more research you do, the more questions you have. So we made a questionnaire to try and start like consolidating beliefs and knowledge into something. We got it down to a 14-item questionnaire. Oh, this slide's got a lot of text, sorry. So we went to experts and we went to kids, got their language, we got the experts' perspectives, clinicians, researchers, came up with this questionnaire. It's much simpler. Hopefully it's accessible. And the preliminary data looks all right in terms of reliability and validity. But yeah, as I said, it always feels like early days. My boss at UTS says that these validation questionnaire studies are kind of like a brick, and then validation is like a wall. So I don't want to overstate or claim anything huge with this questionnaire, but it's a starting point, and a lot of people are using it as a conversation starter. So for instance, it's a 5-point Likert scale. So you might get a question, learning about pain can help you feel less pain. Like that's pretty controversial, right? And then they click disagree, strongly disagree, or unsure, agree, strongly agree. It's not that they're right or wrong. They're just expressing something that they probably wouldn't say out loud unless you gave them the questionnaire. So it's not about memory. It's not about being right or wrong. The language is really simple and it's brief. And what that does, a lot of clinicians contact me, and the feedback is it helps like put things onto the table, but on the patient's terms. It's not you getting up there and, all right, here's Walden-Melzak's textbook of pain. You need to learn this. What I learned at that lecture is like, you learn about transcriptomes, blah, blah, blah. Like, we don't need to maybe give all of that information. Let the patient generate and ask the questions. And I guess the metaphor I think about is it's like they're in the driver's seat. It's not you being like, all right, buckle up. Like, I'm going to give you a 2-hour lecture. Like, they're in charge of the learning. It's not about you as the teacher. I'm speaking to the clinicians in the room. But for researchers, I guess it's a really interesting challenge of like, how do we find out the way someone thinks? If you want to have a look, there's a digital version. I've put it online as well. You can scan that or type that in. There's a paper version. You can email me. Happy to chat. Very, very, very approachable. Happy to hear more. I think I was asked to come and speak here to just share some like resources, some stuff we're trying. Again, I don't have all the answers, but we're having a go. So in my lunch break when I was working at Westmead Hospital quite a few years ago, I was not before research years. I just started my Masters of Research, and we're telling these patient anecdotes, and you're hearing every conference, everyone's saying these same stories all the time. It's like, wouldn't it be cool if there was an animation? So we did that and made some videos. And a lot of people are reached by them, and like kids watch them. They're in university lectures. Again, it's a really good conversation starter. I don't think it's the whole thing. I don't think it's the answer for everything, but a small bite-sized resource seems to help. I wrote a paper comparing that top video to the Tame the Beast video. If people have seen that, Lorimer Mosley led that project. And it's kind of just going, well, TED Ed, like you sign over ownership. And so as the content expert, it's scary. Like you don't know what the final product's going to look like. Whereas if you have 60 grand up front, you can make a video and control all of those creative decisions. So that if you're interested in it, I think a lot of smart people are in the room. You should make these videos. It's really fun. But the challenge is working out like which path do you kind of take. So there's a paper if you are interested in that. The kids' books, I'll just quickly run you through the knowledge translation, kind of some of the hurdles that we hit. So 5 years ago, we knew some of the kind of key messages that work for adults. We have better data on that now in terms of recovered patients' interviews. We had some pediatric research, but we needed a little bit. If you have kids, you know that they love children's books. They return to them. They read them lots of times rather than being a one-off, one of those annoying YouTube videos of a kid unboxing something. The thing about a kid's book that's really nice is it's like character driven. It's not about the learning outcome. So it's not like a textbook. The kid sees a role model and they copy them. And we see this in the studies we've been doing, which is really cool. Psychologists call it a social story. You get to hold it in your hands. I love hardcover, fancy color, thick pages, all of that's nice. For clinicians, the feedback we're getting is like it anchors your education. So you can look at one learning outcome each week. We're planting lots of seeds rather than giving all the answers. We did a single case experimental design recently, and over 6 weeks, we tracked kids and the way they thought about pain. And it changed surprisingly more than we thought it would. I kind of thought, once someone thinks that, I don't know, pain, more damage would mean more pain, that belief would be pretty stable over a 6-week period. But they did a series of interviews, they filled out questions, and we just have so many more concerns on the stability of this construct. Does that make sense? Yeah? Okay. We did lots of rounds of feedback. There's 26 experts reviewing these books. We went to kids lots of times. As I said, it took years. Each book only covers one key message. It's cartoon style, action oriented. There's lots of diary entries, relatable. There's a success story. This is a big deal in educational literature, is to be able to see someone who's done a good job at the plan or whatever the solution is. And then my condition on being an author was we have to have a freely available, like the bulk of this needs to be freely available. So we made an online portal, all the stuff is printable. And so that's really nice in terms of me wanting to be equitable and not letting just English speakers or people in a certain country having access to certain information. And it's based on the latest research. So I guess the point of this slide, having lots of dot points, is it's hard. And we thought we knew what we're doing 5 years ago. We had no idea. And we probably still, there's still lots of gaps. It's really, really challenging. This is what the books look like. I think at a minimum, my minimum claim would be that they're good conversation starters. And hopefully beyond that, maybe they have a preventative effect. A lot of people get overwhelmingly excited because something's shiny. And so as the researcher in me gets worried about that. But this has driven so much more research progress than I could have done by writing another paper that not many people see in the echo chamber of Twitter/X. Okay, a few pediatric things to get out there because I think it's helpful to hear. A lot of people who work with adults just go, oh yeah, so kids are the same, you just got to simplify it. But I think it's different at different stages of cognitive and emotional development. And I guess what I'm saying there is being developmentally sensitive. So from about the age of 8, kids can fill out a questionnaire, validly on average they can. But then from the age of 12, they can start thinking abstractly. And so clinicians and the data showed that that's a hard age group because the parent has a lot of influence. They don't really understand a whole lot about their pain yet, but then they're kind of becoming a little bit independent. And so, yeah, anyway, so that was the age group we focused on in my PhD. But with the kids book, kids read up. So indie kids and 6-year-olds are loving this, which is really interesting. So for an older kid who's too cool, like the 11-year-old who's oh, I don't want to see comic books, I'm into Harry Potter, whatever. The way that there's a study in the US doing this, they're saying to them, hey, I know these books are for younger kids, but do you think a younger kid could understand it? And so then the teenager has to understand it in order to then critique it. And I think that's a really healthy thing. The next generation, we want them to be critical of stuff. And then the younger kids, the text may go over their head and it might be more about, oh, what do you think Zoe's doing here? What do you like about this picture? And that's the conversation starter. So my goal is to develop resources that are developmentally sensitive so that we can hopefully target the minimal amount of education. So it's bite-sized. Hopefully it's more interactive than chapters in a single book. And one thing that was really nice is we got to create a world. So the same characters feature in each book and there's development of all that. And it's really exciting. There's different rhyming pattern in each book, lots of sneaky learning. So the comic style is very interactive. Kids keep coming back to it. It's not just I've learned a series of fun facts about pain and they don't apply to my juvenile idiopathic arthritis. It's, wow, I can't believe Zoe's cousin did it. And then in the last book, Zoe got back to school. Maybe I should, and it just raises these curious questions, which I think are really helpful. There's lots of diary entries, and that seems to be a huge hit, which I was surprised by. And at the end of each book, there's interactive activities, and then that takes you to the online portal, and then that's to videos, and the curriculum can grow out. And we're doing a study with teachers at the moment where we're just giving them the basic, really, really basic stuff about pain, and then letting them apply their teaching behavioral frameworks. And some of the preliminary data is we're seeing more empathy in the playground and just outcomes we weren't even planning on. So that's guiding our future research, which is cool. That's what the online portal looks like. So you can print stuff off. Anyway, if you want to have a look, very happy to share that and you can check it out. One of the things that was happening in parallel to these books is Hayley Leake's PhD. And she went through data of adult patients who had recovered, and these were common learning outcomes that they reported. So we'll just use the blue one. Thoughts, emotions, and experiences affect pain. We'll go with that example. The next year, they went back and forward with a bunch of patients and experts and came up with some learning statements. And again, this kind of idea features. When it comes to pain, everything matters. So the idea here is there are biological, psychological, and social influences on your daily moment-by-moment pain experiences. Can't say that to a kid. They wouldn't understand that. The way that we do that in chronic pain clinics was about this idea of a volume dial. If anyone has a young baby or toddler, it's crazy. They can turn the volume on the TV up very, very young. So this metaphor of turning the volume up or down is not like this anymore for anyone who's old enough for a dial. It's a plus and a minus button. And so we talk about it's a concrete sentence. So many things turn up the volume of my pain, turn them down. And then they go, what do you mean? Which things? And then the book explores some ideas. And then there's a study that each book's based on a scientific study. That one's the one where there's a red and a blue light in the room influencing average pain experience. And it just raises lots of questions, things to discuss. Again, it's not giving necessarily answers. It's more making society, hopefully, more curious. So you can see how those kind of the different ways of saying it in an abstract way can somewhat be translated to pediatrics. But I think it's better to start with the kids' language and work our way up. Yeah. Oh, here's a little clip. Actually, this is fun. I'll shut up for a second.
You're about to get hurt.
Yeah.
Your sensors send electrical messages to your brain,
Oh, sorry.
up to your brain, and your brain says, should I make pain or not? If it does not, it's normally because they don't think there's a great possibility of you getting hurt. But if they do, then it's like, it's a great possibility.
His dad was a physio, by the way. I found him
Thank you
interesting.
for watching, and don't forget to like and
Yeah,
subscribe.
kids they just have to have this. So I sat with kids for a day, and they made all these videos and stuff. It was really nice. But just using the language, the way they approach stuff, I think is really helpful. Anyway, so we'll zoom back to more research to wrap up. This is the SCED study, the single case experimental design. We haven't published this yet, but we're analyzing the data. And I just wanted to highlight all the variability. So let's just quickly explain what's going on. So across, you can see strongly agree, unsure, disagree, strongly disagree. We've just grabbed one item. The item is the brain processes lots of details before you feel pain. It's a tricky item for an 8 to 12-year-old. You can see on day 0, before they had anything, this is like a spectrum of answers, right? No one strongly agreed at that point. Nothing had happened by day 7. Some of them had received the book. So there was a little bit of change, but just maybe filling out the questionnaire caused reflection, something like that. And then they received the book, and they received that. This was a sham book. I can talk more about that if you want. And then this was the draft version of book 1. And we thought that would change their scores. But I guess what this highlighted to us is how dynamic the construct is and how tricky it is to assess. And we did interviews pre and at those yellow time points, and lining up the responses to the interviews with the responses to the survey seemed to be helpful, because then you can kind of go, hey, why is there a mismatch, or why is there a match? Those sort of things. So I'll leave you with this question of imagining if learning about pain was part of the next generation school curriculum, what would that actually look like? There's some great work. Hodges' team does this with adults, and you say, look at all the influences on your pain experience. With kids, we simplified this and we kind of made this idea of there's like little characters jumping on the plus or the minus button. Tried to use a really, really, really simple idea there. Possible benefits are pain isn't as invisible as it was when you were a kid. Maybe participation will increase. The preliminary data definitely talks about stigma now reducing because everyone's aware of it. And then what I'm interested in terms of the big idea is this preventative education. Could we prevent future pain-related disability? Potential harm, maybe if they misunderstand it, they might think pain's all in their head, something horrible, and that could make it worse. So we're doing a lot of research. I just wanted to show this slide to finish. This is a lot of the intervention studies from the last little while, but they're almost all recent. And there's so much other work other than intervention studies being done. None of them are on kids' books yet, because there wasn't any at the time. But yeah, there's lots of preliminary findings to suggest this is a good time to target education. And so it's like we need to get the content right, and then we need to work out how to deliver it. But yeah, thank you so much for having me today. I loved being here.
Thank you very much, Josh, for your great presentation. So it is my pleasure to introduce Associate Professor of Clinical Pain Neuroscience, Tasha Stanton. Associate Professor Tasha Stanton leads the Persistent Pain Research Group at the South Australian Health and Medical Research Institute, and is the co-director of the Impact in Health, the University of South Australia. She's a clinical pain neuroscientist with original training as a physiotherapist, and her research explores sensory and cognitive contributors to pain. She received more than $7.3 million in competitive research funding and has published over 110 peer-reviewed journal articles won national and international awards, including ABCRN's top 5 on the 40 science communicators in Australia, and has been a keynote invited speaker at over 100 conferences worldwide. Her specific interests include chronic pain, osteoarthritis, pain education, cortical body representation, somatosensation, and body illusions using virtual mediated reality. So the topic Tasha is presented to us today is why what goes on behind the scene matters, perceptual trickery and its role in pain management. Thank you, Tasha. You have the timer?
Yeah, you bet. Thank you so much. And I'm so excited to get to come here and present. So thank you so much for the invitation. And yeah, I want to talk about a little bit, what goes on behind the scenes and why I think that that might matter, particularly because if we maybe understand what goes on behind the scenes, we can use perceptual trickery or using your own senses to trick yourself to then actually involve this in pain management. So I think it's very tempting to think that everything that we experience is just objective reality. It's just, a readout of incoming sensory information. And yet what we're starting to understand is that everything that we experience is actually influenced by a lot of things that we don't even know about. Let me give you an example of this. This is a very famous illusion, rotating mask illusion. You'll see it's rotating to the right of the screen, but now it's just shifted and now it's rotating towards the left of the screen. But the reason this is famous is because this mask actually isn't changing direction rotation. But your brain has learned that faces curve outwards. So it would rather have you see this change direction than have you see a weird inward curving face. And what I love is that we now know, but you cannot unsee the illusion. So these behind the scene processes are powerful. And as Josh brought up, I don't know if I can stop this, the study that he referenced, this extends to pain. If we touch you on the skin with an ice cold probe and we shine a red light first, or we shine a blue light first, it matters. The same ice cold probe hurts significantly more if it's a red light shone first. And if people are asked what they felt, they report that that probe is painfully hot. They get the entire percept wrong. Why? Well, we've learned, haven't we, that red is hot and maybe dangerous. Blue is cold. And why I think we should care about these type of experimental findings is that what we're seeing is that they seem to extend to clinical conditions. So this is some work that we've done with dental specialists in Western Australia in people who have burning mouth syndrome. So this is burning pain in the tongue and oral mucosa. And we used a technology called mediated reality, where what we do is we alter real-time video. So you see your own body, but it changes in front of your eyes. And we compared a normal red-colored tongue to then an inverted condition where we gave them a blue tongue. We made them a Smurf. But what we found is that when they had this blue tongue, that burning pain significantly reduced in their tongue. So it suggests that some of these behind-the-scene processes might still be working in clinical pain conditions. And so we are starting, of course, to understand that this incoming sensory input, there's a lot going on. There's extensive filtering, integrating, modulating, prioritizing of different information, all before it ever enters our conscious awareness and we experience a percept, we experience something. So there's a lot going on behind the scenes. But we also bring our own story to that. We have our past experiences, we have our expectations, which means that actually all of us create our own individualized perception. Now, I've been intrigued by one of these behind the scene processes that is called sensory modulation. And this really refers to the ability of information from one sensory source to modulate or change information from another. And there's particularly interesting links between vision and nociception, and then the resultant experience of pain. And specifically looking at vision of your own body. So this is some work done some time ago now, but they showed if you're zapping people with lasers, so it hurts, it matters what you see. So that same laser zap hurts significantly less if you're viewing your own hand than if you're viewing a block. But we're weirder than this. It doesn't just matter if we're looking at our hand. It seems to matter the size that we see that body part to be. So if we have a burning probe on someone and we show them the hand at the right size, we show them their hand too little or their hand too big, that same probe hurts more if the hand is little. And it hurts less relative to the normal size if that hand is big. And so I've been intrigued and wondering, does that extend to clinical conditions? So we've been working with people with painful knee osteoarthritis and using, again, this mediated reality technology to change how their body part looks to them. And we've particularly looked at this illusion called a stretch illusion, where we elongate how their joint looks to them. And I'm going to show you a video of this. I want you to imagine your leg is straight out in front of you and you're looking down at the top of your kneecap. And so what happens is, as it visually elongates, we gently pull on the calf towards the foot. So your brain is getting information from vision and from touch that your limb is truly changing size. And of course you consciously know it isn't, but it feels like it is. So we recruited people with knee osteoarthritis. We had them undergo lots of different conditions. We didn't tell them which was the real one, randomized order, and we looked to see what happened to pain. And what we found was the real illusion significantly reduced their knee pain. Importantly, just pulling on their leg did not. And in this case, just visually changing the size of their leg did not. And in this one, they didn't really feel like it had changed. And this was one illusion. So we saw about a 15% reduction in pain that didn't last too long. What was intriguing, though, is if we repeated that illusion numerous times, we saw a cumulative effect on the magnitude of pain. And we started to see this analgesia lasting anywhere from 2 to 20 minutes. So one of the things we're doing now is we're following this up and we're saying, can we use this perceptual trickery for good to hijack these behind the scene processes and maybe actually provide this analgesic window for people to exercise in? Can we make their knee feel better before we ask them to exercise? And this is being led by my PhD student, Erin McIntyre. But guys, we always want to push the window, don't we? Push the envelope. We're trying to see how far can this go? How much can we push how we change your body? And so we did this study looking also to see if we could shift these more kind of nuanced perceptions about your body, about your ability to do things. So we took people with back pain and we had them do a lifting task, but we showed them their back under different conditions. So they're wearing goggles, mediated reality. We asked them to basically pretend that they had a mirror in front of them, a mirror behind them, and they're seeing the reflected image of their own back. So they're seeing their back. No illusion, looks normal. Bigger condition, we just made it a bit bigger. Stronger condition, as you can see there, we put a ridiculous bodybuilder's back over their own back and it moved with them. And then we checked to see what happened to their lifting experience. And this is case study data of one person that had chronic back pain and also had impaired back perception. So really wasn't certain when he was moving it, how far he'd moved, tactile acuity, wasn't able to localize touch very well, and just generally had a poor impaired perception of his back. And for this person, he was able to take on or embody that ridiculous muscle back. And when he did, he had the lowest pain intensity relative to the other conditions during the lifting task, the lowest levels of fear, but also it improved perceived strength and his confidence in doing that task. But what was really interesting is when we compared to other people that did not have impaired back perception, they weren't able to take on that crazy muscle back. So this sparked something, and we thought, in these people that have perceptual dysfunction, we might actually have this window of opportunity because they seem to have enhanced sensory malleability. They'll take things on much easier. And so to decide if that was something worth putting time into, we explored this idea of perceptual dysfunction a little bit further. And we developed a questionnaire for people with painful knee osteoarthritis. And we just said, does this matter if you have perceptual dysfunction? And what we found is maybe yes, because when your knee feels wrong to you, so you've got high levels of perceptual dysfunction, you tend to be worse off clinically. So you have more pain during motion, you have higher levels of disability, higher levels of pain catastrophizing and fear of movement, and greater generalized anxiety. But not only that, is it seems to matter to your response to treatment. So if we give people exercise-based treatment, so this was 3 months of physiotherapy exercise, what we found was that people that had high levels of body perception dysfunction, they were the ones that didn't respond. over 80% of them, and we had a high level, it had to be 50% pain reduction, but 80% of people with high body perception dysfunction did not respond to exercise therapy. And then after that, if you had more structural changes to your knee joint, which kind of makes sense. But we also saw that it actually might seem to matter to recovery from things like surgery. So people who had perceptual dysfunction, quite early after surgery, that was very different between those who had developed persistent post-surgical pain and those that didn't. So this is, the red line is people who had persistent post-surgical pain after a total knee replacement surgery for osteoarthritis. They did not differ in perceptual dysfunction at baseline, but as early as 1 month and across the entire follow-up year, we saw elevated perceptual dysfunction in people that had this persistent post-surgical pain. And the last thing that we did to kind of convince ourselves, is this anything, is we tried to think of a scenario where there could be a subjective component and an objective component to this. So we actually looked at people who reported, we got a ton of people to fill in, not a ton, this many people, to fill in a questionnaire about their knee and its size. And we just took their answers to, I feel like my knee is big or swollen, yes or no, and that determined whether they reported that their knee felt swollen. But then what we did is we also did ultrasonography of their suprapatellar bursa. So that's usually the most common area that you see swelling in people with knee OA. And then we characterized them as to whether swelling was present or absent. And so it seemed, we had quite interesting findings. So people that their knee joint neither feels nor objectively is swollen, people with no probs, relative to the people that both had real and perceived swelling, the people that had the swelling had lower quad strength, lower self-efficacy, and higher catastrophizing. However, people that had no objective swelling at all, but they just felt like their knee was swollen, also had all of these things. They also had higher pain intensity, greater disability, and higher catastrophizing relative to people that didn't have nor feel any swelling. And when we compared these two groups directly, so the people that their knee feels swollen and objectively it is swollen, but the people it only just feels swollen, there's no actual swelling, the only difference is that this group that has this perceptual swelling dysfunction, they have greater impairment in other measures of sensory acuity, in this case, tactile acuity. So they have less precision in the way that they're dealing with sensory information. And so this raised this idea, well, this actually might be quite important because actually in some pain conditions, we do see this level of sensory imprecision, and it means we might be able to target it. So we've looked to see whether perceptual trickery might have differing effects based on your level of sensory precision. And so this is work that was led by Brendan Moat, who's now doing a PhD with me. But we created a virtual reality bike that basically gives you different visual cues. This is what it looks like. It's hooked up to a cycloergometer, so how much you pedal determines how fast you go through this landscape in the virtual reality goggles. And you'll see there's hills, there's flats, there's all these different things. But what we did for this experiment is we held the cadence and resistance constant. So we're trying to standardize the physical effort that someone's undertaking, but we're still showing them hills. So what do you think? If you see a hill in front of you, you expect it to get harder. But in this case, it doesn't, it won't. So you get almost sometimes this weird feeling that you're being pulled up the hill. And so what we found is that these deceptive visual cues, they can make people feel better and can make some people feel like they're actually working less hard in exercise, which is awesome because lots of people hate exercise and it's really hard to get them to start. But it's critical. The sensory precision is critical. How accurately you perceive your own heartbeat determines how you go with this. If you're quite accurate at it, we can't make you feel better. If we give you bad visual information, you'll feel worse. But if you don't have very precise sensory acuity or internal detection of heartbeat, actually, we can make you feel better. If we mess with your vision, you do feel better when you cycle. So it suggests that this sensory precision might matter. And this is now being followed up by my postdoc, Dr. Jim Saradakis, where we're exploring this directly in people with painful knee osteoarthritis. Now, I have to go on a little tangent here But the tangent is important because it's why I think that this sensory imprecision and perceptual dysfunction might be important. And it comes back to the fact that it's not just sensory cues that influence what we feel. Obviously, other things like cognitive cues can matter as well. And in particular, the words that we hear, the things that we're told about our pain, as Josh mentioned, about our condition by others and health professionals, they can influence and change what we feel. And even at quite a basic level, words can change what we feel. So for example, if we get people to read different sentences while they've got a hot burning probe on their skin, and these sentences are either literal, so Anna spilled acid on her hands, it felt burning, or they're metaphoric. Eric's team lost 0 to 4, the defeat was burning. So of course the word is identical, but the meaning implied by it differs. It's the amount of pain reported drastically differs. So regardless, when you have that burning probe and you're reading that literal sentence, it hurts more, that same probe, than when you're reading a metaphoric sentence. And you can see there that that upregulation is heightened in people with chronic pain. They're more sensitive to this. But this idea of what you've just done before, these priors, they can have a large influence on the pain that you feel. And so priors can be literally what you've just done. It can also be your expectations, your past experience. But I want us together to experience the power of priors, because I felt like I'm not always convinced until I get tricked. So this is a video. It's just going to take a moment to load. I want you to read the words to yourself on the left-hand side and see what you hear. Green needle. One more time. Green needle. Okay, what word did you hear? Hopefully green needle. We're going to do it again, but this time I want you to read the words on the other side of the screen. Brainstorm. And just for fun, green needle. It's crazy. You only hear the word that you're reading. And so we think this is because when you're reading that, you expect a certain acoustic pattern. And then when we give you this really weird, low quality, ambiguous sound, your brain kind of has to make best sense of what's coming in and seems to sample based on what you expect. And this matters because if we're clinicians, we shape our patients' priors. We provide that information that determines what they think and believe. And this might matter when we think about situations like this. So let's say we've got a person who's got back pain, ages ago hurt the back, but now she wants to get back to tennis. So she's going to play tennis, but decides, I need to be sure. I'm going to go get an MRI and just make sure. Gets the scan back and it says, you've got a disc bulge and it's pushing on a nerve. And she didn't really know what that meant. So she Googled it. And then she saw this crazy picture. And it was freaking her out. So she ended up going to her GP. And the GP was really good and said, no, it's good. Tennis will be fine for you. But just as she was leaving, one of the most common ways to blow out a disc is by bending over and twisting the back. And then what happens? She's playing tennis and all of her sensory input coming from her body is telling her, actually, you're bending over and twisting the back. And if we were able to stick a little thermometer and measure nociception, so to speak, into her back, maybe it was this big at the start. And now once we have all this different information, and based on the priors, there's a change in the way that that information is sampled or prioritized, we can have this upregulation that potentially is giving us this experience of pain, but that might not have much to do with what's going on in the back. And why I'm telling you all of this is let's think back to sensory precision. So if you are imprecise in the way that you know where your body is located, what do you need to do when you're in potentially dangerous positions? First of all, you're not sure, are you, if you're safe? We've shown that there's many cases where safety learning is impaired. But there's also evidence to suggest that you overgeneralize. So you need to have a bigger safety buffer. You're worried, you're not sure exactly where you are. So therefore, I need to be more careful about this range of movement. And this is where I think actually sensory imprecision could be quite important. So I guess one of the big ideas that I bring to this is, what if things that we aren't even aware of, these behind the scene processes, what if they're part of this picture and an important part of this picture for the fact of pain being this emergent phenomenon this thing that it's not just linear, it's lots of different things, a little bit like a traffic accident. It's not always one thing that causes it. It's a accumulation of different things, a tipping point that means then things occur. And so we talked about pain or perceptual dysfunction and sensory imprecision, but we also do have some evidence, and this is being led by my PhD student, Erin McIntyre, that people with osteoarthritis, painful osteoarthritis, perceive the environment as harsher. So if you get them to estimate hill steepness, that's what this is here, they significantly overestimate the steepness of the hill, and much more so than people who don't have pain, and typically at higher degrees of steepness. We also see that people with painful knee osteoarthritis, they have these heightened threat activity associations. So if we do not give them time to think, and they just have to do quick response times, what we see is that they have heightened associations between activity and danger relative to other populations. We also see that people with chronic pain have this altered decision-making related to effort. They'll have a tendency to choose effortless options over ones that you're getting more reward, but it requires effort. And also, they're not aware, but oftentimes they do hold inaccurate beliefs about pain, but it's not their fault because they're reinforced by clinicians, by society. But this is some work that was led by my postdoc, Dr. Felicity Braithwaite, where she was interviewing people who had knee osteoarthritis. And these are some of the messages they're getting. You know what, there's nothing you can do to stop the decline, and so there's no hope. You're never told you may never need surgery. On my scan, I queried, what's caused this? And my doctor just pointed to my date of birth. Like deterministic much. But all of these different things, I guess, where I see value is including all of these different things together and using some of these new study designs, such as our single subject experimental study designs, these N-of-1 designs where we have numerous repeated measures. Maybe we can start to apply these big level techniques such as machine learning to the person and be able to make some of those individualized predictions. So to summarize, many things we're entirely unaware of can profoundly shape the pain we feel. And I think that understanding these behind the scene processes and testing modulatory pathways within individuals may have merit. So this is including psychophysical, neurophysiological measures within clinical trials, within different things to explore mechanisms. But also that I think perceptual trickery, well, first of all, it's just cool, but it allows us to better understand how our perceptions are created and then opens the door, I think, for new treatments. So on that note, thank you very much for your time and your attention.
Thank you very much for all three presenters. So we're now going to start having some questions for you, and if you could join us here at the front, that would be great. And I apologize from our online audience because it would be a bit impossible for us to go both in the auditorium and online. So if that's okay, I will start with the questions here and then we go to the group. That's fine. I'll start with one question for each of you. That's fine.
Yeah.
Naveen, the question I have for you is that what are the challenges and considerations in translating cell and gene therapies for neuropathic pain from basically your principal studies to clinical trials?
Yeah, great question. So what I've shown is a bit like science fiction because we start with like a preclinical model, but obviously safety is the major concern. And that's why we did all these experiments. Like we inject and then we profile the spinal cord to see what are changing, what are the neurons that are changing. And then what we've seen is our first version, this 1.0 version of our cell therapy actually affects a lot of cells, not just the ones that are driving neuropathic pain, but also the other ones that are not affected. So obviously we need to refine that even more. So besides safety concerns, other challenges include, and that's something that we've recently realized as we try to commercialize these things, we reach out to VCs for investments and stuff, and they start pointing out all these gaps, like all these things that we need to address, that we should have probably thought of way in advance. Things like how can you scale? How can you produce a large amount of like
of your cells or your gene therapy. Because these are everything that we do right now. These are small scale in a dish sort of things, and for us to scale it, you have to think of like, how can I fit in a bioreactor? How much can I produce, like, tidal wise and all that. So those are things that we need to think of. And finally, I think it's a long-term like efficacy. Because so far we've for these transplants, we've kept them up to like 6 months. And they seem to like provide quite long-lasting relief, but how does that translate in humans? We don't know yet, and there will be significant regulatory like hurdles that we have to overcome. If you look at the current cell therapy like field, it's just CAR T cells that have been approved. There's no such thing as neuron transplants yet, so it might be a while before we even hit that point. But hopefully in the near future. But yeah, we need to address all these first.
And do you think there might be any gender differences there? And
Good question. So I didn't mention this, like all the data that I showed today, it was all male mice, but we've also repeated in female mice as well. And we see the same pain relief. So in our hands, in this preclinical model, no sex differences, but we don't know in humans, like maybe there will be. We'll have to see. Yeah. Thank you.
Thank you very much.
Yep.
And Joshua, the question for you I have, especially with your educational background as well, is that what have you learned about teachers, educators being involved in healthcare that might translate across to other fields?
Yeah. Interesting, isn't it? Like, so teachers are trained purely as educators and clinicians are not trained typically too much about education, but they often are delivering it. And even Tash said, like, inadvertently educating people by saying, gee, I've never seen a back like that, or whatever it is. Like, that is education. It's just the opposite of education. So yeah, one of the studies actually just the other week, we're in a school and hearing the teachers talk about pain, but without using any clinical words was just really interesting. Like, so they think so much about the behavior of a group of people, a class, way better than a clinician. Like the groups of clinicians, when you see them learning to educate or things like that, even in a university setting, it's like, I've got to get every single fact perfect. Whereas an educator, a teacher in a classroom kind of carries the burden of the class, like, and they're thinking about well-being. They're doing all these other behavioral things so well. And I think we have a lot to learn from that kind of area and bringing that into clinical practice. Or can we embed the good bits of the clinical practice and put it into a preventative space? And I think it could go either way. So yeah, I don't really know the answer yet, but I'm super fascinated. And so if anyone knows teachers who want to be involved in studies, we're very, very keen to keep expanding.
Thank you very much.
Yeah.
And Tasha, enhanced sensory malleability. The device that you had with the knee OA testing, I remember there were only 2 of them in Australia or in the world. Is that correct?
Yeah, so the big brute model, that's the research model, you're right, there's not very many in the world at all. We recently, the work that I was referring to about trying to do an analgesic window, as part of that, it's funded through Hospital Research Foundation. And the main aspect of that entire grant is actually to be like, we need to get these research models into clinical forms. So it's sort of a co-design study and a feasibility study working with clinicians to try to embed that within a clinical setting to see, first of all, can we do it? And also, do we see similar results that we see in the research lab as we might in the clinical setting? So we've got used to be a Mirage, which was this enormous beast that just actually looked terrifying walking up to, but now it's down to a tablet that just connects to the bed. So it's portable, it needs a little bit of proper lighting, but nothing much. So it's much better.
So it kind of leads to my next question.
Sure.
That in clinical setting, do you think such a device can be usable now?
I would say not yet. We don't have good enough evidence to suggest that we should start embedding things like that. I think we need to do those big trials, but we're doing that first step so that you can maybe do it. I guess where I see is I don't see this as being a standalone treatment. I see it as really probably having merit as an adjunct. And part of the challenge, I suppose, there is with that is, and it relates actually a little bit to the educational world in the field, but depending on someone's view and understanding of pain, sometimes that makes absolutely no sense. And so I do think that there's probably an aspect where first of all, having a way to explain it and to give credibility as to why we might think that this would occur, which of course would be part of the non-specific effect of the treatment. But also, I think, having a way that we can create that language that you're not overstepping the bounds of accuracy and you're not simplifying too much, but you're providing, like you would for any intervention, a rationale for why we're doing it. So I do think that there's a couple aspects there that would have to be tackled.
Thank you very much. And there are a lot more questions, but I would like to give the opportunity to our audience.
Thanks for all your talks, very interesting. I tried to think of a question that maybe would tie together all the different areas, because of course I think it really highlights the challenges we have in the pain field and really how many ways we can go at them. And I thought to ask if you could imagine in a perfect world where all of the hopes and ideas that you have about your research actually went all the way to fruition, where would that be, one? And how long would it take? I don't mean like 5 years, 10 years. I mean like within a decade, within 2 decades, or within more. Because I think that really is interesting, perhaps, for people.
Should I start first? So in an ideal world, I would say maybe a decade or two, depending on like how, like, I feel like in the past few years, we've seen this like gradual acceptance of cell therapy and gene therapy. And, you know, if it all works out preclinically in our models, and then I would say maybe a decade or two. And you have a follow-up question to that? Yep. What would the outcome be? Oh, yeah. Yeah, so obviously I was studying neuropathic pain, right? So the outcome would be a one-shot like administration of a therapy that provides long-lasting pain relief. That's like the hope. That's what we hope we can achieve. So, you know, patients won't have to rely on chronic re-administration of drugs. That's kind of like what we're trying to achieve. Yep.
Yeah, for me, I guess like running a huge RCT, big numbers, and we follow kids into adulthood and long term, ideally. So that would take decades just doing the study. But yeah, to see if like all preventative research is just so tricky. If you get into the nitty gritty of any preventative study, it's just very, very hard to attribute like which causal factor was a causal factor and all of those kind of things. So just that research angle is really hard to like in terms of having big level cohort data and following control groups and all that kind of stuff. At like a local angle at the moment, like one of the, like we're talking with different Australian curriculum like changes. And so thinking like, oh, maybe top down is a good way to test curriculum change. Like if we get everyone to change, like probably better than some of the gobbledygook that's in, like there's some stuff out there that's being taught that is very, very hard to understand as a researcher. And I'm like, oh, at least this could be a little bit better, but we don't know if it's really good. And so it's like, if we could implement that now everywhere across the world, that would be great. And after years of meetings with different public bodies, that is a slow moving journey. But we've identified specific gaps and points in the curriculum where it might fit. But in the independent schools and private schools, it's a very different beast. Like often the principal just does stuff and things just change. And so we see like one school just recently like embraced it way more than we wanted. And it was great, but like, and it had a good outcome from what we could see, but it was a bit scary because we're like, we're not ready yet. But they just wanted to go all in, like, let's get the kids developing projects, and they make Spotify podcasts and posters and publish this. And it's like, whoa, I don't know if we just want to see if it's feasible yet. And so like, I guess my dream would be to see like really thorough curriculum change happening, but then public messaging and then clinician messaging. So each of those things, like there's different PhD students working on different angles at the moment, but we don't know really if one will take off. And I think we need to be opportunistic a little bit, like in terms of grant funding. So I think in the next 5 years, it will just depend on the next immediate steps, but hopefully within 10 years or so, we've achieved success in each different angle. Like, so top down change, change in schools, change in like public messaging, change in health professional education. And I think once we work out some of those systems and how to change things, then the process of change becomes easier. Like, because when you look back at the slip, slop, slap thing, for instance, it's just like, oh, that's so easy. Like, we all just need to wear hats and then reduce skin cancer. And it's like, at the moment, we don't even know, like, is it pain-related disability? What are we trying to change here in the really long term? Like, what is actually achievable? And so working out some of those targets is a good thing. I don't know, sorry, I don't really know the answer, but that's the point of a conference like this, right? It's ideas, it's not answers.
I think that's such an interesting question because I think
I decided to take off my microphone. I don't know. I think I suppose what gets me excited is when we can think about the way that we can combine some of these different techniques instead of kind of going forward in these different silos. And I just love the idea of being able to, embed some of the more mechanistic stuff. And oh man, there's just so many of the cool things that you guys do. And I'm like, I wish we could do this.
Yeah.
But our people are alive.
Yeah. I know it's kind of hard. Yeah.
Which we want. I'm happy with that, just to clarify. But I think there's so many things that would benefit from having embedding it within each other, like even getting to see, for example, when you have someone undergoing, getting this education in schools, like what's the key bit that changes? Is it that knowledge change? What underpins it? Do we see all of a sudden the brakes of our pain system start working again? Do you know what I mean? Like I love to find some of those things, and not saying that it always is one thing, but I guess if we can explore, I guess I do feel quite strongly that when we explore some of the mechanisms behind things, at least we can create hypothesis or informed hypotheses going forward. Hypotheses, I can't speak. But it is interesting because I do think that is such a challenge, is to try to see where we can be when you do have a lot of different people going in different directions. But if I had the ideal thing, I think it would be so cool if you rocked up to a clinic, let's say, I'm going to give it 30 years time. This might be slightly optimistic, but you can kind of go through a series of different tasks that might say, this might be a great place for you to start. It's not necessarily, and I think we do that with our clinical decision making, but that it often is built then based on past experience, not necessarily some of the, let's say mechanism driven things. But yeah, hard, but good question.
Thank you very much. And we have time for one more question.
It's Josh, is it?
Yes.
Yeah. I was interested, first of all, you had that analogy, or you're using the slip, slop, slap analogy, which was way before my time. But it was, way after my time. But that is really for a public health message for everybody. Whereas you're talking about people with children who are going to develop chronic pain or in pain, and they're 1 in 5. So is there the risk, if you put it in a curriculum, say, of medicalizing all these other kids?
Great question. I should clarify that. So early on, a lot of this education was only in kids with chronic pain, but what we are seeing is the benefit, if we don't over-medicalize, the benefit of like the empathy and the stigma kind of piece. Like if we don't give too much information, but we give enough to talk about the invisibility of pain and maybe some of the complexity of the contributors, like even maybe just that message of many things can turn the volume of pain up or down. Like that's not scary information, but yeah, I agree. Like maybe thinking about pain too much could drive someone to become hypervigilant. So yeah, it's a real question that we need to grapple with. And I think it's an important one. And we were kind of shocked that the target could move on to kids without chronic pain. But then when you speak to a room of clinicians, a lot of them are like, oh, if I knew what I know now about the complexity of all this science, I do think that protects me from developing disability. Like I am less afraid of moving or whatever, if it's a physio crowd. But in some settings, it's like, oh, we need to be really careful and you need this certain medication in order to do this, or whatever the beliefs are in that kind of crowd. So I don't think there'll be a one size fits all, but maybe there's like this minimal effective dose that's like a starting point and a good conversation that's not causing harm. That's where we want to land. Does that answer the question? Yeah, okay, great.
Many thanks to our presenters, our audience, also our online audience. You can definitely approach the presenters for more questions. If that's okay, please join me to thank our presenters. So for our online audience, there will be a poll that asks for your input. So please make sure that you provide answers to the poll. For everyone here or online, please feel free to join the Sydney Pain Consortium if you're not a member yet. Is that working? Perfect. And also, please join us for drinks outside, and there is more opportunity for networking. I also want to thank our organizing committee, Associate Professor Claire Ashton James, Dr. Susanna Park, and Jing Wang for her amazing organizational skills. Thank you very much. It was a pleasure to have you all. Thank you very much. And for our support team at the back as well, Fran, thank you. Thank you. All the best. Yeah.